Thank you so much, Sue, for that lovely introduction. Just going to line up. Now, good to go. So you're very welcome to my talk this afternoon, which is Optimum Iron Dosage in Pregnancy. What does the evidence tell us? I'd like to sincerely thank all of you who are watching, but also in particular the All Ireland 2021 Maternity and Midwifery Festival for this opportunity. And of course, Active Iron for their sponsorship. So just to highlight again, I'm a writer, speaker, midwife, childbirth educator, and I'm a passionate educationalist, not just for the women and families in my care, but also disseminating information to my fellow midwives and obstetric colleagues. And importantly, this presentation is sponsored by Active Iron, who are an Irish company. More of that later. So to introduce, iron is a vital micronutrient. I'll just be reflecting on a little bit of anatomy and physiology to remind us all how important it is. The current guidelines as they stand at the moment, the current challenges of supplementation. Why is it so challenging for pregnant women and for their infants to get the amount of iron daily that they should? Deficiency, a progressive journey. We sometimes very much focus on anemia, but that very much is the end of a very long road, and the idea that deficiency and the opportunities to perhaps prevent it can happen much, much earlier on. And my ultimate point, prevention is better than cure. Could a lower dosage offer the solution? And of course, hopefully some questions if you have any of those. So iron, as we know, is a vital micronutrient, but just to remind ourselves just how important it is. It's essential for oxygen transportation, energy metabolism, cognitive function, blood cell formation and self-division, among a myriad of others, contributes to a healthy immune system. And that, I think, has been brought into sharp focus during COVID and the pandemic in, I suppose, the opportunities we have to disseminate information that can improve people's general health and improve their immune system. Globally, it is the most common nutritional deficiency. It is estimated that 2 billion of the world's population and 800 million women suffer with iron deficiency. And interestingly, unlike a lot of other nutrition deficiencies, it affects low, middle, and high income countries. So no matter where you live, you will be affected by this. It's estimated in Western countries, up to 25% of pregnant women may have iron deficiency anemia. And globally, the World Health Organization estimate that 50% of pregnant women may be deficient. So risks and effects of mother and baby of iron deficiency. Well, depletion of iron stores and ferritin levels. Ferritin levels are basically there as a backup. So if you're not getting your daily amount, you're going to dig into your ferritin levels. Impaired hemoglobin production, which is especially important during pregnancy and the increased need to transport oxygen to the fetus. Obviously, anemia, increases susceptibility and severity of infections. So not only do you pick up bugs more easily, but when you do, you tend to be more unwell with them. Poor cognition and low productivity. And I suppose that one in particular can be an issue because we put a lot of stuff down to the normal things that go alongside pregnancy, when in fact, perhaps a deficiency could be part and parcel. Increased risks of maternal mortality and morbidity, and fatigue, shortness of breath, palpitations, depression, low mood, and irritability are all risks and effects. In the baby, iron deficiency in the first 3 months of life, when you have an iron deficient mother, obviously you have a more propensity to have an iron deficient infant. Low birth weight and preterm birth, congenital abnormalities, cognitive impairment, and increased risk of perinatal mortality and morbidity. So quite startling, really, the effect of the nutritional deficiency on both mothers and babies in our care. So what are the current guidelines? What is anemia and its definition? So it's described, anemia is defined as a hemoglobin of less than 110 grams per litre in the first trimester, 105 grams per litre in the second and third trimesters, and 100 grams per litre in the postnatal period. The British Committee of Standards of Haematology, the BCSH, and NICE recommend an FBC at booking and at 28 weeks, and that a serum ferritin should be checked in women who, although not anemic, are at increased risk of deficiency. So who are the women in that group who are at increased risk of deficiency in pregnancy? So low iron stores before pregnancy. And this is a really interesting one because we know that a lot of women, one of the first times that they might get a full blood count is in fact in pregnancy. A lot of women wouldn't have had recently a full blood count. So they may be totally unaware that they're deficient. And remember, in a lot of places, serum ferritin isn't checked on a lot of women, even if they are at a bit of extra risk, because it's a more expensive test and it's just it's not as used as widely, but hopefully that will change. So you might look like you're not deficient, but your stores might be significantly impacted. Previous history of deficiency, pre-existing blood condition such as sickle cell or thalassemia, a young mother below 20 years of age, a gut disorder such as IBS or celiac disease, an eating disorder or a previous history of an eating disorder. Again, something that sometimes women are not likely to disclose in an antenatal appointment or in their checks. And restricted diets. More and more of us are either vegetarian or vegan, so we wouldn't get our RDA of iron from our food. The current guidelines for iron intake on pregnancy. So we know that there is a natural hemodilution in pregnancy. There's a 2 to 3-fold increase in iron requirements tied into this. The plasma blood volume increases by 50%, but the red blood cell count only increases by 33%. So that natural hemodilution predisposes, unless you have the correct amount of iron daily and the correct iron stores, that anemia is more likely, or iron deficiency is more likely, which may lead to anemia. And we know that a healthy mother is a healthier infant. If we have healthy mothers who have the correct amount of iron in their diet, they have a much more likelihood of having a healthier infant and that their health continues as a family moving forward. The CDC recommend 27 milligrams of iron daily in pregnancy, and the WHO recommend 30 to 60 milligrams of iron, which is actually quite an enormous amount. So the challenge is getting enough of iron via our diet. Why is it so challenging to get that amount of iron? To put it into context, to get 30 milligrams of iron via a vegetarian or vegan diet, you would have to eat 10 cups of cooked spinach to get in anywhere close to the amount of iron. And that's only the iron that you're taking in. That's not the iron that you're absorbing. So that's an enormous amount to have to ingest on a day-to-day basis. Remember, that's every day. More and more people are on restricted diets. Once, and this is a really important point, once a pregnant woman is deficient, a diet alone will not replenish levels. So once a woman is deficient, you can eat as much spinach or food as you need, as you like, but you won't ever replenish the levels that you need. So that's why supplementation and early supplementation, I argue, might be key. Ferritin stores will be exhausted. So as I mentioned earlier, unless they're checked themselves. An FBC can give not an exactly clear picture of whether somebody is suffering with a deficiency or not. Women may become deficient in between booking and recheck, and this is really important. So let's say a woman presents herself, gets her FBC done, it looks like it's fine, she's not instructed to go on iron, but her ferritin stores have actually been really dug into that period, and she doesn't get her iron rechecked until 28 weeks or sometimes later. It's very possible that during that period of time that the women in her care might become deficient. And many women need the addition of iron in their diet via supplementation for all of the reasons I've said, but very much so because we just have a huge difficulty in actually getting the amount of iron, absorbing the amount of iron through our diet. And because the needs in pregnancy, as I said, increase that need 2 to 3-fold. So supplementation. Traditional oral supplements, what's really good about them? Well, they're very, very low cost. They're readily available. They're easy for people to access. But what are the problems of same? Well, there are a lot of side effects, a lot of gastrointestinal issues and upset, huge amount of constipation, and all of these leading to non-compliance. So we know if people are suffering very badly from iron-related issues of supplementation, they are far less likely to continue on taking them. It's also very important to understand the whole idea of bioavailability. Supplements are not created equally, in that I say some iron supplements, although despite their claims, may have a negligible iron content. That's very true, particularly for liquid iron supplements. So women might believe that they're taking plenty of iron in their diet when in fact they're not. The bioavailability varies drastically. So for example, somebody might take 300 milligrams of ferrous sulfate, but actually the elemental iron that's available to them might be very, very much less, 60 milligrams, for example. And within that, only 10% of that might be absorbed. It's important to remember as well that iron is absorbed via a carry mechanism. So it's absorbed much further down in the stomach, in the duodenum, in fact, right at the bottom. So that gives, unfortunately, to some iron supplements that a lot of the iron is actually destroyed, and a lot of it, all it does is causing the side effects, the GI issues, the constipation, and therefore it makes things very, very challenging for women. So deficiency is progressive. Again, just to highlight, it's a sliding scale. In a normal woman, there's normal iron stores, the normal transport of iron, so the iron that's usable in the bloodstream, and then functional iron, the iron that's actually been used for specific functions around the body. Stage 1, iron depletion, digs into your ferritin and iron stores, but your transport iron and your functional iron remain stable and fine. But stage 2, mild functional, you're deficient, your iron stores are depleted, your transport iron is depleted, but your functional iron might be okay. But again, that might lead to functional iron deficiency, i.e. anemia. So as you can see, there are a lot of stages before we actually get to anemia. And that's, I think, really important to highlight. It's those people that perhaps are the ones that we could really, really help by, well, how do I suggest? Well, treating iron deficiency in pregnancy. How is it treated traditionally? Iron deficiency anemia, we know, has enormous health implications for both mum and baby. High dose oral treatments increase the side effects. So if you have somebody that has a progressive or quite serious deficiency that's picked up late, they're put on a high dose oral supplement to try and get the balance right again. But this is going to give them some severe side effects a lot of the time, meaning that they're not keen on taking it or they have a very uncomfortable time. And as well, the normal GI upset, constipation can be exacerbated hugely by the iron, but they can also be a normal part and parcel of pregnancy. If that treatment fails, IV iron treatment, which we know it's uncomfortable, it's costly, and can be far more challenging for mum and the healthcare provider to provide. Preventative supplementation, what I'm suggesting, can decrease maternal anemia at term by 70%. And what do we mean by this? Well, my argument is that the solution is health optimization. Prevention is far better than cure. And I was delighted this year in September that I had a paper and supplement published in the British Journal of Midwifery on my opinion and argument on proactive treatment deficiency to prevent anemia in pregnancy, and was delighted to get the support of Active Iron for that as well. So what does the evidence tell us? Well, there's an increasing body of evidence that suggests a lower iron dosage supplement could be key. So lower dosage taken earlier and sustained right through pregnancy. That prevents the deficiency in the first instance. So we literally get in before the problem occurs, which as midwives, we're the experts in the norm, sounds like a pretty good idea to me. This ensures that iron stores can cope with the increased demand in pregnancy and can compensate for any fluctuations. And there's less side effects for mum. So with active iron in particular, you have far less side effects. So people are much more likely to be compliant and take the supplement daily along with whatever else they need. Midwives have a key role in information dissemination. It's a huge part of my role that I'm so passionate about, and why I'm such a fan of not only this product, but about disseminating the correct information that's evidence-based. So in all, we could ensure less intervention and less women becoming medical patients. I know there's been a real, I really enjoyed some of the talks earlier on focusing on the kind of the wider abbreviations of what's normal now and the change of what's normal. And the more women that we can consider and keep within the normal bracket, then the more likelihood that they can have midwifery-led and less medicalized care. And of course, health optimization and ensuring that they're not deficient in things has to be a key part of all of this. So why active iron and why am I so passionate about it? Well, it's clinically proven and evidentially proven that to have twice the absorption compared to standard ferrous sulfate. So it's better absorbed, you have much more iron available to be used, and therefore the dosage can be much, much lower. The active iron formulation helps provide gut cell protection, allowing lower doses to be administered and improved gut tolerability. And on tolerability, 9 out of 10 users in the studies compared to 1 out of 10 in the normal, actually said that they tolerated it incredibly well, which is an amazing thing for women and an amazing thing for a supplement such as this. Just to let you know, anybody watching, you can get a free sample of active iron. Any midwives or health care workers watching, you can just follow that link and request a sample and check it out for yourself. So what are my conclusions after, I think I have read in the last 20 years, pretty much nearly every article on iron in pregnancy. It's taken a long time, but I'm happy to say that I actually have been able to come to these conclusions based on the evidence that I have learned myself. So iron deficiency and the possible resulting anemia have far-reaching health consequences for mum, baby, and the wider global community. Getting the optimum iron intake in pregnancy can be extremely challenging, and early intervention to encourage maintenance of iron levels throughout pregnancy may preclude the need for much more expensive and risky and uncomfortable treatments. Preventing the deficiency in the first instance could be a key objective of maternity provision and should be a key objective of maternity provision. Midwives have a key role in health optimization, in education, in providing holistic women-centered care. And I truly believe that health optimization during pregnancy may ensure more women are considered low risk, ensuring more choices of care for them and more midwifery-led care pathways. So thank you so much for anybody watching, and I invite any and all questions.
That's great. Thank you so much, Avril. That's very crisp and very clear, as always, as a presentation. It's lovely. And we haven't had any questions coming through now. It occurs to me, because and it occurs to me also that people can get their free sample and try it out for themselves. And I was thinking, well, I wonder how many midwives themselves are a bit low on iron stores, because of course it's more likely to be women who have got less iron stores just because of menstruation, for example, or if they've had several babies, for example, and they've let their iron stores go down. I'm not sure if you've done any work in that area.
No, women are more likely. So in the general populace, if you just took 100 women of menstruating age, you're talking anywhere, depending on which article you read, anywhere between 10 and 30% in Western countries and up to 60% in lower income countries. So it's like internationally, it's a huge problem, but it's particularly, I suppose, focused in on pregnancy because of the 2 to 3-fold increase in need. So if you're slightly deficient outside of pregnancy, you can be damn sure you will be definitely deficient in pregnancy. And unfortunately, we're missing that kind of huge bracket because a lot of units aren't checking ferritin levels. You can have people that appear to have sufficient amount of iron in their FBC, but are just maybe digging into their ferritin stores. By the time they come in at 28 weeks, I suppose horse has bolted. And then it's a lot more difficult and challenging to try and get those numbers up in the 3rd trimester when we have a lot more instances of gastrointestinal upset, heartburn, constipation anyway. So to try and then flood them with this high dose treatments and a lot of discomfort therein, my suggestion is getting in there, being aware of the information, getting in that you're so much more likely that taking a small amount much earlier on and throughout really may preclude the need. I mean, there's ongoing research in this area. And yes, this is sponsored by Active Iron, but the reason I'm so passionate about this, Sue, is I really, really believe in health optimization. And I really believe that this product offers an amazing, I suppose, chance to get in there and stop people getting sick, from anemia or certainly from deficiency in the long term. And I'd love to get that message across.
Yeah. And I think also your sort of emphasis on the amount of spinach you'd have to get through.
Yeah, it's a lot.
If you like, even if you like spinach, that's a lot of spinach. Yeah. And of course, many of the women, I mean, this can be a part of the assessment that you make when you first meet the woman, but a lot of women are not eating necessarily what we would call a healthy diet, which is one of my things that, you can ask women, are you eating a healthy diet? And many women will say yes, but actually when you ask them, they're not on an optimum diet at all. And especially, obviously, even vegetarians can be on a quite low mineral and iron particular
absolutely, and folate levels. And we know that despite what we know, that the evidence tells us that diet habits don't radically change in pregnancy. If you don't have a great diet before, while you might try and add in a couple of things, your diet doesn't change radically. So if you are deficient in any kind of nutritional aspects prior to, you have a far greater increase in being deficient in them during. So it doesn't change. And also it's health optimization. So by changing habits during pregnancy, we're in the hope of not only producing generationally more healthy infants, but also then that continues on the puerperium, and that, I suppose, for the whole family and for the wider, for the wider public at large.
No, that's grand. Now I'm going to turn, because as you know, I've got 2 screens, and that's where the questions are coming in. I've got a question from Nessa O'Malley. Nessa.
Yeah.
Hi, Nessa. Sorry about my pronunciation.
One of my former absolutely lovely colleagues from the Coombe. Okay. She's a wonderful midwife.
Fabulous. Well, thank you, Nessa. And she says, thanks for the very informative talk, Avril. Is there any evidence that you know of to suggest athletes are at a higher risk of iron deficiency prior to pregnancy?
Yeah, it's funny you should. It's funny you should say this, and I'll actually I will send you some of that. But there has been a huge amount of work done, actually, really only in the last 2 years, examining this, and the iron requirements for athletes, particularly top level athletes, are not dissimilar to the iron requirements in pregnancy.
Oh wow!
Because so yes is the simple answer. Yes, they do. And now I haven't looked at it they've been looked at in kind of a separate area to pregnancy, but one would lead into the other. It would suggest that if you have a high level athlete that's at a high level, then they might be at increased likelihood. However, their diets are usually much better. So maybe a low dose supplement might be the ideal thing. But Nessa, I will send you the information I will have.
Fabulous. Well, Nessa, that's a good question, because we always say that women going into labour are like marathon runners. So that sort of keys in quite well to the idea of the athlete's needs being similar to a pregnant woman. Great. Okay. We've had Asli Est Ecker, and she says, I thank everyone for their presentations and organisation. And this is Asli from Turkey. So thank you, Asli. Glad you're enjoying it. It's not quite over. There's two more sessions to go yet. And then I have a comment from Nicola Clark. Great talk, Avril. As a midwife for over 40 years, I believe in the importance of iron in pregnancy. Yes, we'd often say take tablets every second day if they can't take the standard, and it usually works. Great to see it on paper. Okay, that's grand. So that's a comment more than a question. That's grand. Okay. Something floated through my brain there, and I'm not sure if it was about athletes or nutrition. It'll come back in a minute anyway. I don't know if there's any other questions coming through, or you wanted to say you have about 3 minutes, Avril, if you wanted to do a postscript to your session, which was fabulous.
Yeah, it's been a really interesting area of study for me, and reading all of the different, I suppose, information. You know, there was a huge amount of study done a number of years ago, and then it kind of just stalled a lot. And I think that's what sometimes happens in midwifery, and to a lesser extent obstetrics, that sometimes we accept something as is, whereas modern science can make something far better. And we should be a little bit more open to, just because it's been done for years and years doesn't mean we can't do it a lot better. And I suppose that's what I'm really proud of that Solvatron and Active Iron have done. They looked at it, they built it on real evidence and real scientific discovery, and made it far, far better. And I'm really proud to kind of be associated with that, because it's something I believe in so firmly, in that how we move midwifery and how we move science forward is on evidence, and doing the research and following the evidentiary trail. And just because it's new doesn't mean it's not brilliant.
Fabulous. Well, what a super way to complete. Thank you so much, Avril.
Thank you so much, Sue. And great day, and congratulations to the festival. I've really enjoyed the day.
Fabulous. Thank you so much. I do have a last comment from Carol Reed that's just flicked through. She's saying, I'm coming to the end of my career and find it so interesting. It's something I remember giving all pregnant women, can't you remember it, at antenatal clinics in the 70s, and was removed from routine as it felt not required. It's now coming back into focus, which is exactly in a way what you said, Avril, so beautifully put. And thank you, Carol, for your last comment. That's great. Thank you.